I'd like today to do an examination of the hip and the groin. When you're doing an examination, you must first take a good history, which will give you some good idea as to what your diagnosis may well be. Although we're talking about the hip and the groin, we also must consider surrounding structures, because groin pain and hip pain can actually come from elsewhere, such as your back. When you're looking at an examination of the hip, you should also examine the patient's footwear to see if there's abnormal wear, which may give you some clues as to what's going on gait-wise. You should expose your patient adequately. When we're looking at the groin, we'll be looking at the abdominal area, and also we'll be looking at his legs also. To start off with, we're going to be inspecting the spine. Pop your hands by your side. And what we're looking for is there any shoulder tilt here or shoulder dip that may give us an indication that there could be a spinal problem. We're also looking from the side to see whether or not we've got the normal thoracic kyphosis and the normal lumbar lordosis. Now Mark here has a slightly straight thoracic spine and quite a straight lumbar spine. We're also going to be looking from the back here to see whether or not there is any muscle hypertrophy and whether there's any muscle wasting. You may see some muscle spasm also. Don't forget scars. He could have some fat atrophy where he's had injections. We'll also be thinking about gluteal atrophy, but for the purpose of this and modesty, we've not asked him to take these trousers off. Just turn sideways for me. What we're also going to be feeling for is pelvic tilt. So what we can do for that is put our index finger on the anterior superior iliac spine and our thumb on the posterior superior iliac spine. See if there's any pelvic tilt. I'd like to explain here a test called the Trendelenburg sign. The Trendelenburg sign is looking for hip abductor weakness, and that can be due to either a problem following trauma to the hip abductors, or it can be due to intrinsic hip pathology. And what we do is to ask our patient, I want you to stand on your left leg and bend your right knee up. And what we're looking for is to see whether this part of the hip dips down, which it would be due to weakness here. Okay, and we'll do the same on the other side. And there isn't any dip there at all, so that's a negative, that's fine. Trendelenburg sign. The next test that we can do here is called the Gillette test, which is looking for sacroiliac movement. And what we do then is put our thumbs on the sacroiliac joint. And what I want you to do on both sides, and I want you to lift your right knee up to your chest. And we're looking to see if there is movement with rotation of the sacroiliac joints. And that's normal here, and we do the same on the other side. This test is not helpful if you've got somebody with either a lumbar scoliosis or a leg length discrepancy, or if you've got someone that's morbidly obese and it's difficult to actually palpate these areas. We'd also want to look at some core stability, but I think that's outside the range of this examination at the moment, because that could be quite a long explanation. We want to do some movements. If we can do some flexion for us, just bend forward, touch your toes, and stand up straight. And then we can do lumbar extension, lean backwards, and relax. And go down sideways, touch the outside of your knee. And now the other way. And we're looking to see whether that's fine, whether there's smooth movements, whether we're pivoting in one area, and what his range is. And put your arms up on your chest and rotate around to your left and now to your right. And those movements seem really very good. You can also at this stage do a stalk test, which is looking for either SI problems or lysis. Stand on your left leg, lean backwards and relax, and you do the same on the other side. Right, what I'd like to do now is to just watch Mark walking here. And come back to me. Okay, and what we're looking for there is his gait an antalgic one or a painful gait? Does he have a Trendelenburg gait? Is there any asymmetry of his pelvic movement? Right, we're now going to examine him on the plinth here. What we're going to do now is to just do some lumbar spine movements with him in a sitting position. And the reason for this is because in a seated position, this stabilizes the pelvis and takes out pelvic and hip movements, which you may find, rather than it being lumbar movements, it could well be certainly in flexion. It could be the hip that is giving you the flexion rather than the lumbar spine. So what I want you to do is the same sort of movements we did before. I want you to bend forwards. We're seeing good flexion here. Now lean backwards. That's fine. Go down to the left side and now to your right side. And do your cross arms across your chest and rotate to your right and to your left. And those movements all seem absolutely fine. You're going to ask your patients if any of those movements are painful.
No, not at all.
In order to see whether or not there is pathology going on here. I'm now going to ask the patient to lie down supine on the couch. But before I do that, I just want to mention, when you're taking a history, think about where the pain is coming from. Pain that comes from the front of the hip is often from the acetabulum, or it can be labral tears. It can be from the femoral head, which can be avascular necrosis, or it can be an arthritic problem. Lateral pain tends to come from the greater trochanter region, which could be bursitis. And buttock pain is often due to back pathology, or it can be gluteal muscle pathology. Because the back can be irritated, the buttock pain can be due to sciatic nerve irritation. You can also get buttock pain if you've got hamstring problems. Right, we'll now lie Mark down. Okay, you comfortable?
Yeah.
Right. What we're now going to do is to palpate initially, and we're going to palpate. I don't want to expose Mark too much, so I'm going to do this a little bit by feel. But I'm going to palpate his anterior superior iliac spine, which is the insertion of the sartorius muscle. I then come down slightly to the anterior inferior iliac spine, which is where the rectus femoris is inserted. And if you have a problem with either of those two muscles with an enthesopathy, you may well find that that's tender. Then come over medially, and you can palpate the pubic ramus. If that's tender, you may be thinking of a stress lesion within the pubic ramus. You're then going medially to palpate the pubic symphysis, and you're going to ask your patient if that's uncomfortable, because that can be due to an osteitis pubis. We're then coming down, just separate your legs a wee bit, into the medial aspect of the thigh, and I'm pressing up here on the origin of the adductor longus. You go slightly posteriorly, and then you feel the origin of the gracilis. Tenderness here can also be enthesopathy of the adductor. Coming slightly laterally and palpating here is the pectineus, which you can get tears in, which give you groin pain. We move laterally, palpate over the greater trochanter, which may be due to a trochanteric, give you pain as a consequence of trochanteric bursitis. Can we just roll you over? We're then palpating around the origin of the hamstring, which is over the ischial tuberosity, and we can palpate down the hamstring to see if there is any tenderness. And ask your patient, any pain?
No.
We're then going to palpate in the area of piriformis, and I often find it's quite useful to roll the femur in internal and external rotation when I do that. We're also going to palpate over the sacroiliac joints to see if there is any tenderness on either side here. Any tenderness?
No.
Right, we're now going to do range of movement. To start off with, we want the patient to do the movements, so that is active movement. Then we're going to do passive movements, and then we're going to stress the end of range movements to see if it's uncomfortable. So what I want you to do first of all, lift up your leg straight, that's fine, and down. And now push your leg out this way as far as you can, and relax. And now go across that way. It's okay, leave that where it is, but just go across. That's fine. That's excellent. Now I want you to bend up your knee, and I want you to twist your leg out, foot out that way, and now go the other way. Okay, that's fine. And we'd do the same on both sides and assess. Then I'm going to do these range of movement tests myself. The two things I want to tell you small tips about is when you're doing abduction, you can feel for the pelvic movements, and that's the end of range. Or I want you to relax this leg as much as you can, so I don't want you to resist me at all. Okay? And you can go this way. And if your patient is nicely relaxed, what happens is when the pelvis starts to move, that toe comes medially. All right? So, and that tells you what the range of movement is. As far as your internal and external rotation is concerned, you ask your patient if that's painful at all. And if I can tell you the normal range of movements that are quoted, I find are not particularly accurate in the respect that some people that have hypermobility have much greater range of movements. But the range of movements that are quoted are abduction is 30 to 50 degrees, adduction is 20 to 30 degrees, and external rotation between 40 and 50 degrees, internal rotation 10 to 20 degrees. In order to do an adduction test properly, this leg often gets in the way. So one little tip to do is ask your patient to drop that over the edge, stabilize the pelvis, and then come across. And you'll get a much better idea of what the adduction is because the other leg doesn't then get in the way. You'd also want to check for extension. Can you turn onto your side for me? And you do the extension with the leg, with the knee also in extension, because if the knee is flexed, that will limit the amount of extension of the hip. Cradle the lower leg and just come back, and you're feeling for when you feel the pelvis move. And usually extension is around 20 degrees. Okay, turn onto your back. Right, what I'd like to demonstrate now is a test that's called the Thomas test. And this is positive if the hip is in flexion when we get the patient down. And what I'm going to do is ask him to bend up his left knee, and then I'm going to take him back onto the couch and look at what's happening with his right leg. So if we can just bend up your left knee as far as you can, and then I'm going to take you back and lie you down. Well done, that's fantastic. Keep your knee where it is. And what we're looking for is this straight, or is it slightly, is the hip in a slightly flexed position? Now, this can be slightly flexed due to a number of different things. One is a tight iliopsoas. The other is some intrinsic hip pathology, such as osteoarthritis. The difference between the two, if it's tight iliopsoas, you can overcome it by just a little bit of pressure. But if it's an intrinsic hip pathology, usually it's a solid end feel. The other two things that can give you a positive test here is tightness of the rectus femoris. If that's the cause of the hip flexion, you just straighten the leg, and the leg should then drop down. Okay, bend your knee a little bit again. Or it can be due to a tight IT band, and the way to tell if it's that is you abduct the leg slightly and watch to see if the hip then drops. That's the Thomas test, and it's positive if there is flexion here when you get the patient to lie down. What we're now doing is to examine for the hip flexors. And the hip flexors are the superficial hip flexors, which is rectus femoris, and the deep hip flexors, such as iliopsoas. Now, the way to differentiate between pathology in each is, one is get your patient to hold your leg to about 45 degrees there, and I'm going to try and push down. And if that's painful, then it's more likely to be a rectus femoris problem. The deep hip flexors, you get your patient to flex their knee and their hip to 90 degrees, and then resist me pushing you down. Is that painful?
No.
So if that is painful, it's more likely that that's an iliopsoas problem. Obturator problems can occur deep within the pelvis, and you can isolate those by putting the hip into 90 degrees of flexion, knee 90 degrees of flexion, and medially rotate. You then activate those muscles by asking your patient to push your knee that way towards the curtain. So push, and that's painful with obturator problems. We're then going to test sartorius, and you do that, put your heel on your shin and run that down your shin and then pull up. And if you've got a sartorius problem, that's uncomfortable. And then look at another test called the Faber test. And the Faber test is hip flexion, abduction and external rotation. This will give you pain if you've got some intrinsic hip pathology, if you've got hip flexor pathology, or if you've got SI joint pathology. And the SI joint pathology, particularly if it's the anterior ligaments that are a problem. So this test, the Faber test, leads you really just to further testing to isolate some of those. What we're going to do, put your foot there, and I want you to drop that knee out. A little bit of pressure. Is that painful at all? So that's called the Faber test. Some other tests, there's two tests for looking for stress fractures in the femur. You can get stress fractures in the neck of the femur or even lower down. And one is called the fulcrum test, and you can do this either in a lying or in a sitting position. But basically you get your patient, bend up your knee, you put a clenched fist underneath here, okay, straighten up your leg, and you push down hard there. So you're trying to open up any problem there within the bone. And another test would be the percussion test, where literally you just push on the heel. Any problem? No. Or you can have them to bend their knee up and you push down. Or you push on the greater trochanter and see if that's painful at all. There's pain can come from piriformis, which is a muscle deep in the buttock, and to stretch that and to test it, ask your patient to cross the leg, and now what I want you to do is to bend this knee up. Any pain? And if the piriformis is damaged or particularly tight, they may get problems within the actual buttock here. Just want to talk to you about a condition called the snapping hip syndrome. And there are 3 different causes of snapping hip syndrome, which gives patients either a snap or a pop, which is usually painful. One cause is the iliopsoas, and that gives anterior hip pain, and it's where the iliopsoas catches on either the lesser trochanter or the iliopectineal ridge during extension. The second is caused by is lateral pain caused over the greater trochanter, and that is some catching of either the gluteus medius or the tensor fasciae lata. The third would be either a loose body or labral tears. How do you test for each of those? First one is the iliopsoas, and what you do with your patient is you bend up their knee, so you go into flexion, you go into AB or abduction, and you go to external rotation, and then you go into extension. And if your patient has got a problem there with his iliopsoas, that will either give a pop or a snap, which is painful. The next one would be for the greater trochanter. Ask your patient, turn onto your side for me. And what you're doing then is to put the hip into extension. Relax, just relax. And you put the hip into internal and external rotation. So that's external rotation and internal rotation. And a positive sign would be if that was painful. Keep the hip in extension when you do it. While we're here, we could do an Ober's test, which is a test for a tight IT band. And what you do then is you put your thumb and your index finger to stabilise the pelvis and get your landmarks. One is the anterior superior iliac spine, and the other is the posterior superior iliac spine. So, and you want the femur in line with the spine when you're doing this. Just relax your leg totally. If you put the knee in too much flexion, you'll get a false negative test. And what you're doing is you get them to just drop their knee, just relax, and you're looking to see when you get pelvic movement here. Okay, and if they get movement when you come to the neutral, just past the neutral position, if you get immediate movement then that's a positive test. Okay, just turn onto your back again. The third reason for that snapping hip syndrome, as we said, was either a loose body or a labral tear. Now, labral tears are often difficult to diagnose, and quite often patients are said to have this type of pathology for 2 years before they're actually diagnosed. What you do to looking for that is get your patient to flex their knee, you adduct, and you internally rotate. Is that painful? And if you've got an anterior superior labral tear, that test is often positive. To test for a posterior lateral tear, you get your patient on your side again. I'm sorry we're moving you around an awful lot. But what we're doing then is putting the hip into flexion, slight flexion, and we're going to internal rotation and external rotation. And then we're extending the hip, and we're doing the same. So this is quite a cumbersome test. It's difficult to do, but we're going into flexion with internal external rotation and then coming into extension. Any pain? No. And you're looking for pain or a snap or a pop again. And the final test for the actual pelvis itself is called a pelvic symphysis stress test. And what you're trying to do is you're finding the ASIS, and then you're putting the heels of your hands on. Sorry, I'm turning my back on you. And you're putting downward and outward pressure on. And you're stressing two things there. One is the pubic symphysis, and the other is the SI joints. Just the final thing to talk about is hernias. Now, hernias can give you discomfort here in the groin, either because of an inguinal hernia, which is found above the ilioinguinal ligament that goes from the ASIS to the pubic symphysis. And that can come either from the deep inguinal ring, which is called an indirect inguinal hernia, or it can come more medially when it's called a direct inguinal hernia. And the test for that would be to get your patient standing, coughing, and feel for a cough impulse. The other test that you can do for a sportsman's groin also has lots of other names, but the sportsman's groin often will give you pain over the external inguinal ring. And one way to identify that is to pop your finger up into the scrotum, and you should only be able to get the tip of your finger into the scrotum. I won't actually do it in this patient because of modesty here, but you should just get the tip of your finger in. If your finger goes up, certainly up to the distal interphalangeal joint, that means that that ring is dilated and may well be due to a sportsman's hernia. You get them to cough, and that's often a painful procedure for them to do. That's the video of examination of the hip and the groin.